Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization with the mission and vision to further both education and research in the discipline of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 3, Bone Metabolism and Wound Healing. So to start off Lecture 3, we're going to just refer to our references here. Much of the photographs in this presentation were taken from Human Anatomy and Physiology 6th edition by Elaine Marieb, and some of the information was taken from Wikipedia. So let's talk about developmental aspects of bones. Basically, the mesoderm gives rise to embryonic mesenchymal cells which produce membranes and cartilages that form the embryonic skeleton. The embryonic skeleton ossifies in a predictable timetable that allows fetal age to be easily determined from ultrasound sonograms. At birth, most of the long bones are well ossified except for their epiphyses, and the epiphyses are not ossified in order to allow growth. So in terms of a few definitions, we'll talk about the osteoblasts, a cell that secretes the matrix for bone formation, the osteoclasts, which are giant, large multinucleated cells that resorb bone, and finally osteocytes. So an osteocyte is basically an osteoblast which has become embedded in the matrix in which it has secreted, which has become mineralized. And more or less this is all to form sort of the basic structure, the osteon, which in many sort of other sorts of levels goes on to form bone. There's a picture of that in here. You can see the Haversian canal system that provides the blood nutrients to the bone, the canaliculi and the lamellae, which go on to form the osteon. And then you have the lacunae within these osteons, which contain the osteocytes. Then you have the osteon of the compact bone and the trabeculae of spongy bone. You have the Volkmann's canals, which basically help sort of bridge the Haversian canal system. And then finally, you have the outside covering of periosteum, which also provides some vascular innervation. So by age 25, nearly all bones are completely ossified. In old age, bone resorption is what predominates. A single gene that codes for vitamin D docking determines the tendency both the tendency to accumulate bone mass early in life and the risk for osteoporosis later in life. Bone formation happens by two ways: endochondral ossification and intramembranous ossification. This is important because the majority of the long bones in the body formed by endochondral ossification. The majority of the facial bones or the facial plates formed by intramembranous ossification. Some people have mentioned when it comes to things like bone grafting, is there a difference between bone grafts taken from endochondral versus intramembranous sources, considering the fact that we're using these bone grafts in oral implantology in the face. I'm not aware of any one study that finds a difference. However, we just cite this point for interest's sake. So we'll start off with stages of intramembranous ossification. Basically, the first thing that happens is an ossification center appears in the fibrous connective tissue membrane. It's selected centrally located mesenchymal cells which cluster and differentiate into osteoblasts, forming an ossification center. The next stage, stage 2, the bone matrix, which is osteoid, is secreted within the fibrous membrane. So osteoblasts begin to secrete osteoid, which is mineralized within a few days. The trapped osteoblasts become osteocytes. Step 3, woven bone and periosteum form. So accumulating osteoid is laid down between embryonic blood vessels, which form a random network. The result is a network instead of lamellae of trabeculae. Vascularized mesenchyme condenses on the external face of the woven bone and becomes the periosteum. Step 4, a bony collar of compact bone forms and red marrow appears. So the trabeculae just deepen to the periosteum thicken, forming a woven bone collar that is later replaced with mature lamellar bone. Spongy bone, consisting of distinct trabeculae, persists internally and its vascular tissue becomes red marrow. So endochondral ossification. This basically begins in the second month of development using hyaline cartilage bones as models for bone construction or scaffolding. This requires a breakdown of the hyaline cartilage prior to ossification. So the formation of the bone collar, the cavitation of the hyaline cartilage, the invasion of internal cavities by the periosteal bud and spongy bone formation, the formation of the medullary cavity, appearance of secondary ossification centers in the epiphyses, and ossification of the epiphyses with hyaline cartilage remaining only in the epiphyseal plates in order to facilitate long bone growth later on in life, are the stages of endochondral ossification. So to diagrammatically animate this, we're looking here at the formation of the bone collar around the hyaline cartilage model, which is, so you can see the hyaline cartilage, the blue scaffolding on the left. There's a bit of a bone collar, which is a primary ossification center. This then cavitates within the hyaline cartilage level, the hyaline cartilage model, and you get basically blood vessels of the periosteal bud and spongy bone formation via an invasion of the internal cavities by the periosteal bud and the spongy bone. You then get a medullary cavity. So the formation of the medullary cavity as ossification continues. You get the appearance of secondary ossification centers in the epiphyses in preparation for stage 5, which is ossification of the epiphyses. When completed, hyaline cartilage remains only in the epiphyseal plates and articular cartilage. Postnatally, we get growth in the length of bone. So cartilage on the side of the epiphyseal plate closest to the epiphysis is relatively inactive. Cartilage abutting the shaft of the bones organizes into a pattern that allows fast and efficient growth. Cells of the epiphyseal plate proximal to the resting cartilage form 3 functionally different zones, the zone of growth, transformation, and osteogenic. Functional zones in long bone growth. The growth zone, the cartilage cells undergo mitosis, pushing the epiphysis away from the diaphysis. The transformation zone, the older cells enlarge, the matrix becomes calcified, the cartilage cells die, and the matrix begins to deteriorate. And then you have your osteogenic zone where new bone formation is occurring. So this is diagrammatically showing you long bone growth and remodeling. So long bone growth and remodeling. Growth in length, the cartilage continually grows and is replaced by bone as shown. And in terms of remodeling, bone is resorbed and added by appositional growth as shown. So appositional growth of bone. So the osteoblasts beneath the periosteum secrete bone matrix forming ridges that follow the course of periosteal blood vessels. As the bone ridges enlarge and meet, the groove containing the blood vessels becomes a tunnel. 3. The periosteum lining the tunnel is transformed into an endosteum, and the osteoblasts just deep to the tunnel endosteum secrete bone matrix, narrowing the canal. As the osteoblasts beneath the endosteum form new lamellae, a new osteon is created. Meanwhile, new circumferential lamellae are elaborated beneath the periosteum, and the process is repeated, continuing to enlarge bone diameter. So hormonal regulation of bone growth during youth. During infancy and childhood, epiphyseal plate activity is stimulated by growth hormone. During puberty, testosterone and estrogens, which initially promote adolescent growth spurts, cause masculinization and feminization of specific parts of the skeleton. These are later will induce epiphyseal plate closure, which will end longitudinal bone growth. Bone remodeling. Remodeling units adjacent osteoblasts and osteoclasts deposit and resorb bone at periosteal and endosteal surfaces. Bone deposition occurs when bone is injured or added strength is needed. Requires a diet rich in protein, vitamin C, D, and A, calcium, phosphorus, magnesium, and manganese. Alkaline phosphatase is also essential for the mineralization of bone. Sites of new matrix deposition are revealed by the osteoid seam, which is the unmineralized band of bone matrix, and the calcification front, which is an abrupt transition zone between the osteoid seam and the older mineralized bone. Bone resorption, which is accomplished by osteoclasts. Resorption bays are grooves basically formed by osteoclasts as they break down bone matrix. Resorption involves osteoclast secretion of lysosomal enzymes that digest the organic matrix and also acids that convert calcium salts into soluble forms. The dissolved matrix is transcytosed across the osteoclast cell, where it is secreted into the interstitial fluid and then into the blood. So there's an importance of ionic calcium in the body. Calcium is basically needed for 5 major things: the transmission of nerve impulses, for muscle contraction, for blood coagulation, for secretion by glands and nerve cells, and finally for cell division. So the control of remodeling, there's 2 loops that basically will regulate bone remodeling. Number 1 is the hormonal mechanism, which maintains calcium homeostasis in the blood. And yes, the bones are a calcium reservoir for the body. And number 2 is the mechanical and gravitational forces acting upon the skeleton. So we'll cover this hormonal mechanism first. Basically, rising blood calcium levels trigger the thyroid to release calcitonin. Calcitonin then stimulates calcium salt deposition in the bone. Falling blood calcium levels signal the parathyroid glands to release parathyroid hormone. Parathyroid hormone signals osteoclasts to degrade bone matrix and release calcium into the blood. Diagrammatically, this is a picture of what these 2 look like. The response to mechanical stress. So Wolff's Law, very, very important. A bone grows or remodels in response to the forces or demands placed upon it. Basically, more force, more bone. Observations supporting Wolff's Law include: long bones are thickest midway through the shaft where bending stress is greatest, and curved bones are thickest where they're more likely to buckle. So this is a picture to demonstrate femoral head. The other thing we know about stress is that trabeculae form along lines of stress, and there are large bony projections where heavy active muscles stretch. An example would be the greater trochanter on the femur. So what happens when a bone breaks? Stages in the healing of a bone fracture. So the first step when a bone breaks is you get a hematoma formation. So torn blood vessels hemorrhage, and a mass of clotted blood, a hematoma, forms at the fracture site. The site becomes swollen, painful, and inflamed. Number 2, you get the formation of a fibrocartilaginous callus. So the fibrocartilaginous callus forms. Granulation tissue, a soft callus, forms a few days after the fracture, and capillaries grow into the tissue, and phagocytic cells begin cleaning debris. The fibrocartilaginous callus forms when osteoblasts and fibroblasts migrate to the fracture and begin reconstructing the bone. The fibroblasts secrete collagen fibers that connect broken bone ends. Osteoblasts begin forming spongy bone, and then osteoblasts furthest from capillaries secrete an externally bulging cartilaginous matrix that later calcifies. Step 3, a bony callus forms. So in this bony callus, new bone trabeculae appear in the fibrocartilaginous callus. The fibrocartilaginous callus converts into a bone-hard callus. Bone callus begins 3 to 4 weeks after injury and continues until firm union is formed 2 to 3 months later. Step 4 is you get bone remodeling. So excess material on the bone shaft, exterior, and in the medullary cavity is removed. Compact bone is laid down to reconstruct shaft walls. Homeostatic imbalances. Osteomalacia. Bones are inadequately mineralized, causing softened, weakened bones. The main symptom in these patients is pain when weight is put on the affected bone. This is caused by insufficient calcium in the diet or by vitamin D deficiency. Rickets. Bones of children are inadequately mineralized, causing softened, weakened bones. As a result, clinically, you'll see bowed legs and deformities of the pelvis, the skull, and the rib cage, which are common. And these can be caused by insufficient calcium in the diet or once again by a vitamin D deficiency. Osteoporosis. It's a group of diseases in which bone reabsorption outpaces bone deposition. The spongy bone of the spine is the most vulnerable, and this occurs most often in postmenopausal women. Sometimes the bones can become so fragile that sneezing or stepping off a curb can cause fractures. So fragility fractures like a distal radial fracture or a hip fracture. So in terms of treatment of osteoporosis, calcium and vitamin D supplements are usually recommended for people who are osteopenic in order to prevent progression. Things like increased weight-bearing exercise, especially at a young age, in order to form more bone is recommended. Hormone replacement therapy with things like estrogen can slow bone loss. Natural progesterone creams prompt new bone growth. Statins can increase the bone mineral density. And then there's also the use of bisphosphonates in order to reduce osteoclastic activity. And this is going to be something which we're going to touch on. Bisphosphonates are basically a class of drugs that prevent the loss of bone mass used to treat osteoporosis and similar diseases. They are the most commonly prescribed drugs used to treat osteoporosis. We know that bone undergoes constant turnover and is kept in balance by osteoblasts creating bone and osteoclasts destroying bone. So bisphosphonates will inhibit the digestion of bone by encouraging osteoclasts to undergo apoptosis or cell death, thereby slowing bone loss. In implantology, we need bone turnover. We're basically doing surgery on a patient's bone, despite the fact that there is no real way to predict who's going to develop what they refer to as bisphosphonate-related osteonecrosis of the jaw or medication-related osteonecrosis of the jaw. Patients who are taking oral bisphosphonates or even IV bisphosphonates, oral being more common than IV, one needs to increase their index of suspicion for the development of these sorts of conditions. We do know from the literature that bronze occurs more likely with patients who have taken IV forms of bisphosphonate, and we also know that in terms of incidence, in terms of surgical site, that this occurs more likely in the mandible than the maxilla. There are some well-cited treatment regimens for this condition should it occur. However, I would recommend if a patient is taking bisphosphonates that one consider this to be a relative contraindication to the placement of dental implants. Paget's disease, characterized by excessive bone formation and breakdown. So Pagetic bone with an excessively high ratio of woven to compact bone is formed. Pagetic bone, along with reduced mineralization, causes spotty weakening of the bone. So osteoclast activity wanes, but osteoblast activity continues to work. And it's usually localized in the spine, the pelvis, the femur, and the skull. The cause of this is unknown. Some people have postulated that this may be viral causation. Treatment includes the drugs didronate and Fosamax. Bone healing. Inflammation is necessary for healing. So early bone healing occurs via specific cellular signaling events. So there's four things. There's the pro-inflammatory, the anti-inflammatory, the pro-angiogenic, and osteogenic. There's a connection between the immune system and bone healing. We talk about progressive loading. So as opposed to just going and loading an implant with a tooth, one of the things that can be done is progressively loading the implant with things that are going to basically apply a decreased force over a increased area for the implant. So we know that the formula for stress is force over area. So if you want to decrease the stress or basically progressively load a dental implant, what you need to do are two things. Number one, decrease the force, or number two, increase the area. And this can be done by basically progressively loading an implant with increased size healing abutments. Wound healing is what we're going to move on to next. Wound healing is basically defined as a staged process involving cells, fibers, proteins, angiogenic growth factors, and chemoattractants and proteinases. This is a process that can be defined in many different ways. Classically, the four classic ways that defined wound healing would be hemostasis, number two, inflammation, number three, proliferation, and number four, remodeling. So let's talk about hemostasis. So within the first few minutes of injury, platelets in the blood begin to stick to the injured site. This activates the platelets as they change into an amorphous shape and release chemical signals to promote clotting. This results in the activation of fibrin, which forms a mesh and acts as a glue to bind platelets to each other. This makes a clot that serves to plug the break in the blood vessel, slowing or preventing further bleeding. Platelets also release other pro-inflammatory factors like serotonin, bradykinin, prostaglandins, prostacyclins, thromboxane, and histamine, which serve a number of purposes, including to increase cell proliferation and migration to the area, and to cause blood vessels to become dilated and porous. Extravasated platelets in trauma secrete molecular mediators that initiate the inflammatory process. These would be vasoactive amines, eicosanoids, and cytokines. So the second stage, second phase, which would be the inflammatory phase or initial injury. So basically this is from minutes to 7 days. This is an activation of the complement system. And in this you get cell signaling for neutrophils and macrophages. You get a platelet aggregate, which releases coagulation and growth factors. And this is stimulated by local thrombin and exposed fibrillar collagen. The platelets release fibrinogen, which, when activated, becomes fibrin, and fibrin. And fibrin is a matrix for monocytes, keratinocytes, and fibroblasts, and it also acts as chemotactic agent for macrophages. So continuing along with the inflammatory phase, damaged and dead cells are cleared out, along with bacteria and other pathogens or debris. This happens through the process of phagocytosis, where white blood cells eat debris by engulfing it. Platelet-derived growth factors are released into the wound that cause the migration and division of cells during the proliferative phase. So going to the proliferative phase or proliferation. Angiogenesis, collagen deposition, granulation tissue formation, and epithelialization and wound contracture occur in this phase. In angiogenesis, vascular endothelial cells form new blood vessels. In fibroplasia and granulation tissue formation, fibroblasts grow and form a new provisional extracellular matrix by excreting collagen and fibronectin. Concurrently, reepithelialization of the epidermis occurs, in which epithelial cells proliferate and crawl atop the wound bed, providing cover for the new tissue. In wound contraction, myofibroblasts decrease the size of the wound by gripping the wound edges and contracting using a mechanism that resembles that in smooth muscle cells. When the cell rolls are close to complete, unneeded cells undergo apoptosis or cell death. So the fourth phase, which is remodeling or maturation. So during the maturation and remodeling phase, collagen is realigned along tension lines. Cells that are no longer needed are removed by programmed cell death or apoptosis. So the other way to sort of view wound healing as compared to the four classic phases is the new model. And the reason the new model sort of came out was, if you refer back to the original diagram when we were first talking about wound healing, a lot of these phases they aren't just start stop and your stage one, phase one, phase two. There's a lot of overlap. So the new model, which basically refers to the early phase and then the cellular phase, sort of helps take this into account. It also works a little bit better in terms of the tissue engineering triad or the tissue engineering models in terms of trying to regenerate tissue. So in the early phase, which begins immediately following injury, it involves a cascade of molecular or cellular events which basically lead to hemostasis and the formation of an early extracellular matrix that provides structural staging for cellular attachment and subsequent cellular proliferation, which leads to the cellular phase, which basically involves several types of cells working together to mount an inflammatory response, synthesize granulation tissue, and basically restore the tissue. The cellular phase can be subdivided into one, macrophages and inflammatory components, which is within the first day or two. Two, epithelial mesenchymal interaction or reepithelialization. This is a phenotype change within hours, and this migration begins on day 1 or 2. 3, fibroblasts and myofibroblasts, so the progressive alignment, collagen production, and matrix contraction. This is between day 4 and day 14. 4, the endothelial cells and angiogenesis, which it begins on day 4. And 5, dermal matrix, elements of fabrication, which begins on day 4, lasting 2 weeks, and alteration and remodeling, which begins after 2 weeks, lasting weeks to months, depending on the wound size. We're now going to talk about the definition of a few other things. So cytokines. So cytokines are basically small proteins that are released by cells that have a signaling effect on other cells or themselves. Growth factors. Growth factors can be a hormone or a type of cytokine. They promote cell differentiation and maturation of specific tissue types. TGF-beta, transforming growth factor beta. This is involved with granulocytes, macrophages, lymphocytes, fibroblasts, and smooth muscle cell chemotaxis. There's TIMP synthesis, angiogenesis, fibroplasia, matrix metalloproteinase production inhibition, and keratinocyte proliferation. VEGF, or vascular endothelial growth factor. This is from mesenchymal cells. This is involved in vascular permeability and endothelial cell proliferation. PDGF, or platelet-derived growth factor. This is involved in the chemotaxis of granulocytes, macrophages, fibroblasts, and smooth muscle cells. Granulocyte, macrophage, and fibroblast activation. Fibroblast, endothelial cell, and smooth muscle cell proliferation. Matrix metalloproteinase, fibronectin, and hyaluron production. Angiogenesis, wound remodeling, and integrin expression regulation. Leukocytes, white blood cells, neutrophils, macrophages, mast cells, and lymphocytes. They play an important role in wound healing as a defense against infection. They also release the release of growth factors is also important in tissue maturation and remodeling, primarily TGF-beta 1 and VEGF. Platelets. These are small irregular cells. They have no nucleus. They're basically fragments of megakaryocytes, and they have a lifespan of about 5 to 9 days. However, they contain growth factor-filled granules. So factors that affect wound healing. So these are broken down into two things. There's local factors and systemic factors. We'll start with local factors. So there's mechanical factors, edema or swelling, ischemia and necrosis, the presence of foreign bodies, and low oxygen tension. Systemic factors are inadequate perfusion, inflammation, diabetes, nutrients, metabolic diseases, immunosuppression, connective tissue disorders, and smoking. So these are all factors that would basically not make wounds heal very well. The definition of primary intention. So primary intention is when wound edges are brought together, sutured or glued, so that they are adjacent to each other. This minimizes scarring. Most surgical wounds heal by primary intention healing. Wound closure is performed with things like suture, staples, or adhesive tape or glue. Secondary intention. The wound is allowed to granulate. The surgeon may pack the wound with a gauze or use a drainage system. Granulation results in a broader scar. The healing process can be slow due to the presence of drainage from infection. Wound care must be performed daily to encourage wound debris removal to allow for granulation tissue formation. Tertiary intention, delayed primary closure or secondary suture. The wound is initially cleaned, debrided, and observed typically for 4 or 5 days before closure, and in this case the wound is purposely left open. Complications in wound healing. So there are 5 things we're going to talk about here. We're going to talk about deficient scar formation, which results in wound dehiscence or rupture of the wound due to inadequate formation of granulation tissue. Excessive scar formation, or a hypertrophic scar, a keloid or a desmoid. Exuberant granulation, deficient contraction in skin grafts or excessive contraction in burns. And lastly, we're going to talk about other things like dystrophic calcification, pigmentary changes, painful scars, and incisional hernias. We're now going to move on to blood-based biologics in dentistry. What is the purpose of blood-based biologics in dentistry? So the main purpose is to promote wound healing, and this has sort of been there's sort of been a horizon of these proposed uses for blood-based biologics in dentistry through time. So we started off in 1978 with Rosenthal and al. With the use of platelet fibrinogen thrombin mixtures to seal experimental penetrating corneal wounds. Then in 1998, there was a proposal by Dr. Marks, platelet-rich plasma, growth factor enhancement for bone grafts. In 1999, Anitua wrote an article about plasma rich in growth factors and the preliminary results of the use in the preparation of future sites for implants. And then finally, what we're going to be discussing in more detail today, Dr. Joe Chokroun, the article is originally written in French. However, when translated, it's an opportunity in peri-implantology, the PRF, or the platelet-rich fibrin. So basically the three things that sort of came into play for use in implant dentistry. First was platelet-rich plasma, and then plasma-rich growth factor a year later, and then platelet-rich fibrin, which has really come onto the market or come onto the scene from a tissue engineering perspective. And the nice thing about PRF as compared to the two predecessors was it releases growth factors for around 7 days, and there's no complicated blood harvesting technique which is required. There's no second spin or any of those sorts of things. Most of this stuff can be done with relatively easy, cheap venipuncture equipment that can be purchased from any medical or dental supply company. There's no need for introducing additional calcium thrombin, and unlike the plasma-rich growth factor, there's no heating of these membranes which is required. So what is platelet-rich fibrin? So basically it's autologous blood platelets and leukocytes concentrated, which is derived without biochemical handling as mentioned. And the cells are trapped in a fibrin network which allows for a slow release of their cytokines and growth factors. So leukocytes are 65% increased in this versus whole blood. There's a better response to bacteria. It's proposed that it mediates the response to the tissue, and that it also releases bone morphogenetic protein. It's also a naturally occurring clot, so this is autologous. This is something which is biomimetic. It takes place within nature. It can act as a scaffolding, which in that tissue engineering triad of requiring cells, growth factors, and scaffolding, it acts as a scaffolding for healing to occur. It's protective in the sense that it basically provides a cover to our surgical site. And lastly, it's a barrier. And if you don't mind me adding this one in here too, it also has what we call the LCF, which is the looks cool factor. So uses of platelet-rich fibrin. So the proposed uses for PRF are things like guided bone regeneration, socket grafting, sinus perforation, and also as a gap filler. So what is the cost of obtaining PRF? So basically what you're looking at, you need to purchase a vacutainer needle. You need the holder for this vacutainer needle. You require a form of a tourniquet, which can be either disposable or of the reusable variety. Alcohol prep pad is required. 2 vacutainer bottles, which contain no coagulants. So there's a red top bottle which you can buy. Usually the 10 ml ones is what we purchase. There's also a yellow top bottle which has a citrate in it, which acts as an anticoagulant. You don't use this for PRF. You require a bandage, and usually we take all of these things and make these little kits, and so we have these little Ziploc bags that we contain these things in my office so that they're easy to get. And then lastly, you need a centrifuge, which you can purchase through any lab supply company for around $300. So all in all, if one wants to take a look at the cost of this and break this down, in our office, generally it costs about $3.12 per patient, not including your time in terms of harvesting the blood and for the amount of time it takes to centrifuge this down. So in the next photograph here, it's basically a picture of these items that I've basically described, placed into a Ziploc bag. We'll look at these now individually. So here is your alcohol prep pad. This is basically standard isopropyl antiseptic skin prep for most patients. We generally place 2 into a kit, and the main reason is if it's the case that we cannot harvest blood from the right arm, we need to move to the left arm and see if we can. That's a better site for us. There's a picture of a disposable vacutainer brand tourniquet. I like using disposable tourniquets just because there's less chance of contamination, less requirements for sterilization and disinfection of these things. However, if you're someone who is concerned about medical waste, there are reusable tourniquets which are available as well. This is the needle holder, which is basically made by a company called Becton Dickinson, and the purpose of this is just something you can put the bottles into. There's also what they refer to as butterfly needles and butterfly needle holders, bottle holders as well. I don't have pictures of these here. However, you can look these up on the internet. Here's a picture of the actual the venipuncture needle. This is made by Becton Dickinson. This is a 22 gauge, 1¼ inch. These are the bottles. So as I mentioned, these are the red top bottles. These are also made by Becton Dickinson. They're called a vacutainer, so there's a vacuum in them. So you actually don't want to engage these into the needle, as you'll see in the video at the end of this presentation. You don't want to engage these into the needle until you're actually in the vessel. And what happens is there's a little vacuum inside here, and this is a 10 milliliter bottle. Basically what it does is it sucks the venous blood into the bottle. So this helps facilitate speed of venipuncture and harvesting blood for the purposes of manufacturing your platelet-rich fibrin. We also include 2 bandages in our little bags. If you want to use Johnson & Johnson bandage, you can. If you want to support your local dental supply company, they also make bandages as well. I personally prefer the cloth-based bandages. I just find that they work a little bit better in terms of sticking onto the tissue, onto the patient. So in this photograph, you can see that we've harvested 2 vials of patient's blood from, I'm right-handed, so I like using the right arm on the patient. So from their antecubital fossa, going to the antecubital vein and harvesting 2 vials of blood from the patient. It's very important to move quickly towards your centrifuge because there's no coagulant inside these bottles. Generally, as a rule of thumb, I'll collect anywhere from 2 to 4 bottles from one patient before moving to the centrifuge, and that will give me 2 to 4 platelet-rich fibrin membranes. I've seen some clinicians collect 6 to 8 for procedures like a full mouth clearance. It's just recommended that if you're going to do something like that, you might want to have 2 centrifuges available. As soon as you collect the first 4, give them to your assistant and start spinning them down so that you're not wasting blood. This is a picture of the centrifuge I like using. I've had this centrifuge actually for a long time. This is made by a company called Fisher Scientific. The Chacroun technique basically asks you to take the blood, spin it down in a centrifuge that's going to be spinning at 3,000 RPM, and we do this for about a period of 10 minutes. There are some studies there are some people on the lecture circuit that argue that you need to buy a specific centrifuge. There's differences in centrifuges and the speeds in the angles at which it holds the blood. So the angle at which it holds the bottle, and this centrifuge, it holds the bottle at 45 degrees. There are what they call horizontal separation units that will basically move horizontally. I'll show you a picture of that in a second. But let's move on over here. So in this picture here, you can see that you can set this dial to 10 minutes. So this particular centrifuge, which can be purchased, as I mentioned, quite affordably for around $300, will spin the bottles down at 3,000 RPM for 10 minutes at a 45-degree angle. You want to place the bottles across from one another so that they're balanced out. So you can see in this particular centrifuge, you can place up to 6 bottles. But as I'd already mentioned, you don't want to, you don't, as soon as you collect 4, start spinning them down. It's also important to make sure that you balance the volume, so you're harvesting a similar volume in each bottle, because if the volume is off, that too will throw the centrifuge off. One final point to note is that if you only need to make one membrane, there's no point in taking more blood from the patient than you need. What you can do is you can take a spare bottle and just break the vacuum seal on it and just fill it up with water and use that as a counterweight for the one bottle that you're going to be spinning down from the patient to make that one PRF membrane. Just please do note that the volume of water has to be equal to the volume of blood. In this picture here, you can see this is another Fisher Healthcare brand of centrifuge. It costs a little bit more than the Fisher Scientific model. However, it too will spin blood down for 10 minutes at 3,000 RPM at a 45-degree angle. If you're looking to spend a little bit more money, you can go out and get this what they call a horizontal separation centrifuge. This is made by a company called Drucker. And the advantage of this centrifuge is that, as you can see from my finger, when this centrifuge actually starts spinning, the bottle, as opposed to being at a 45-degree angle, will go horizontal. And this will actually give you more of a compacted PRF membrane. Sorry, when I say compacted, I mean that it's not at a 45-degree angle. It's going to be flat against the packed red cells. There aren't really any studies out there that I've seen from the date of production of this video that would basically outline differences in characteristics. As I mentioned, there are some speakers on the lecture circuit who have mentioned things about the concentration of growth factors using different types of centrifuges and different angles. However, there really haven't been any studies that I've seen that have satisfied me that there is a difference between any of these. So once this process has been completed, you can see in the picture on the left that the bottle, which is on the left, that there's a bit of a yellow layer which is more flat, and the bottle on the right there's a 45-degree angle. So that's the difference between using the horizontal centrifugation unit or the centrifuge that had the 45-degree angle. So in my office, what we generally do is we spin down two bottles, and the picture on the right you'll see that there's a kidney basin which has been placed some gauze and a cotton plier. And what we generally do is these are sterilized in the sterilizer, and these are also placed right by our Ziploc bags of PRF harvesting kits. And what you do is you basically pop the bottle open, open the bag up first, and using your cotton pliers, pull apart the pieces of sterile gauze, pop the bottle open, and pull the snot clots out. That snot clot would be the yellow portion of the actual fibrin clot, and place these down onto the sterile pieces of gauze. That, you can see, we've done that in the picture on the left. And then basically using the sterile cotton pliers, taking some other pieces of sterile gauze and place them on top. And what this is going to do is, over a period of about 5-10 minutes, is remove moisture from these platelet-rich fibrin membranes, so that they can not be these snot clot looking things, and be something which you can actually use inside a patient. And what remains after you've taken these snot clots out is the remaining platelet poor plasma sitting on top of the packed red cells. And you're wondering, okay, what can we do with this? Well, if you're going to be placing a bone graft in a patient, in this picture here you can see that there's a bone well which has about half a cc of mineralized cortical cancellous 50-50 blend, 250 to 1000 micrometer particle size. And what we've done is you need to hydrate this. I mean, in the old days we just use saline from a bottle or something along those lines. Well, you have something right from the patient. Why not just use the platelet poor plasma, and you can use that to hydrate these bone grafts. And in the next photograph, you'll see that we've taken another piece of the sterile gauze from our that we had in our kidney basin, and basically removed the excess moisture from here. And you can see there's a beautifully hydrated graft ready to use inside the patient. After a period of time has elapsed, the platelet-rich fibrin membranes are ready, so you can see them sitting right there. And when you pick these up with that sterile cotton plier, you'll see that you have this beautiful membrane that's got that you can suture. It's got nice pliability to it. It's easy to adapt. It's thick enough to be fairly robust and have a fairly nice tear strength to it. And the other means by which you can create these PRF grafts is to use what they call a PRF box. And the nice thing about these boxes is that they also have these little plug sections in here, so you can actually make a platelet-rich fibrin plug. So taking that snot clot and putting it into the white hole that is right there, and placing a little weight on top in order to draw out excess moisture, you can see that there's a bit of a platelet-rich fibrin plug that's been placed here. So now what do we do with these PRF membranes and PRF plugs? As I previously mentioned, there's a number of applications for it. From our perspective, It's autologous, it's a barrier, it promotes excellent soft tissue growth. Anecdotally, patients have even told me that there's less pain perception. When you bring these patients back within 2-3 days, even a week later, you'll notice a remarkable amount of healing which has taken place. It saves the patient having to go out and pay for the expense of either a resorbable or non-resorbable membrane in the form of collagen or pericardium or all these other things that are sort of out there on the market, and it just looks really cool. So here's one photograph. Here's another photograph of a patient in whom we place some implants in the second premolar, first molar region, and you can see from the vertical mattress sutures that we used, you can actually create a bit of a tunnel inside some of the tissue, and the PRF is robust enough that you can actually use these little mattress sutures to draw the PRF into the tunnel. It does have an excellent tear strength when used with sutures. In this next case here, you can see we've used it in an anterior on a patient. Let's do a case together. So we have a patient that comes in, and this patient was basically a mid-80 year old lady, lovely patient. She had a bridge that went from her first upper right premolar to her first upper right molar, and you can see that the tooth on the upper right premolar had catastrophically failed, that there was some significant bone loss or pneumatization of the sinus in this area as well, along with bone loss on the corresponding first upper right molar. So this lady, she basically wanted a solution to restore function and to restore some aesthetics for her. There was no caries or any other issue with the onlay that actually was sitting on the first upper right molar. It actually had been inside the mouth for around 40-50 years, just some phenomenal dentistry. So we made the decision, what we just do is section that off and clean that up and re-cement that in for the patient, and then basically it became a matter of extracting the what remained of the first upper right premolar. In this case, placement of an implant would be impinging upon the patient's sinus, and so this patient would require a sinus lift bump procedure, and so we achieved that here. In this photograph, you can see that there's this beautiful ellipse from the sinus graft, along with the placement of 2 implants, along with re-cementation of that onlay for the patient. This is a picture of the actual surgery which had taken place, with the graft material not quite placed yet. In the next picture, you see the graft material has been placed, cleaned up, and more or less what we're going to do here is tunnel around this and take one of these PRF membranes and stitch it into place. And there you can see that the PRF membrane has been stitched into place. I bring the patient back usually about a week later just to make sure everything's healing nicely. And this picture here, you can see the patient healed after about a week. Now the implant in the second premolar region, you can just sort of see there's a fibrin clot there. In the first premolar region, you can see there's just a little bit of the cover screw sort of sneaking out there, but the soft tissue response and the fibrin clot is, it looks great. And we bring the patient back after a period of about 4 to 6 months, and we take a radiograph, and you can see that the bone graft is healed. The widened periodontal ligament that was present on the first upper right premolar is no longer present. That decision to re-cement that onlay was sound. We can see that there is some mild crestal bone loss on that first premolar area. However, when we take a look at this clinically, that's with the healing abutments on. This is with the patient clinically with the healing abutments on. We send the patient away for about a week or two just to allow this to heal up. And when you take a look at the soft tissue response, wow, that's all I could say. If every single patient of mine could have a soft tissue response that looked like that, I would be a very happy clinician. So we go ahead and take some impressions of these 2 implants and send these off to our lab. And in this patient's particular case, given the bone which was present before, and given the fact that we had grafted some bone and the fact that there was catastrophic failure of a previous prosthetic, we decided basically that we'd be giving this patient a fused restoration, which would be basically 2 crowns fused together, sitting on 2 implants, in order to just make sure that this was going to be a solution that would last this patient for the rest of her lifetime. In this picture here, you can sort of see the aesthetics of this case. You can see that is a very nice, acceptable aesthetic result. And in this last radiograph, you can see that the margins of the abutments are sitting nicely on top of the implants, that there's been good maintenance of the bone levels, and that the implants themselves the grafts themselves are looking very nice. So let's now what we're going to do is we're going to move towards a video in which we basically take a look at how we harvest platelet-rich fiber inside a patient. So in this video, you can see I'm approaching this bag that I've described, in which we contain all of our products. My assistant has kindly placed a cloth on my table. I'm spreading out the tourniquet, the alcohol, the needle holder, the needle I'm attaching to the needle holder. I'm going to take my 2 bottles. My assistant's going to take care of the bandage and providing me with some gauze after we harvest this graft from the patient, in terms of just placing the gauze and holding it in place and placing the bandage after. I'm walking across, putting on my bracket table my alcohol, the 2 bottles, and applying the tourniquet. In terms of the tourniquet, you basically tie it down sort of like a shoe. So I'm going to demonstrate that here. I'll show you why. So you tie it down like a shoe, and the purpose is you leave this little tag on the top so that you can grab it easily at the end and just pop the tourniquet off, as opposed to leaving a tight, uncomfortable tourniquet on the patient. So let's reapply that onto the patient here now. And what you're going to see here now is an old tip or old trick I learned from a nurse that basically taught me how to do venipuncture, which is go for the vessel you can feel. Don't go for the vessel you can see, right? So if you feel the vessel, don't worry about seeing it, right? So in this case, I can feel this beautiful vessel in the antecubital fossa, and I'm prepping the site with alcohol. Now, I usually don't normally wear gloves when I'm harvesting blood for patients, and the main reason is just for better dexterity. There was a study in which it was found that you're more likely to needle stick yourself when you wear gloves, because you sort of lose that proprioceptive sense. But if you want to wear gloves, that's fine too. So basically, small pinch here for the patient. Do not also engage the bottle. These bottles, as I mentioned, are vacutainer bottles. So we're going to put this bottle in now to engage that vacuum, and you'll see that with that vacuum, the blood just starts coming out beautifully. Now, it takes some time. Just hold a steady hand here. In dentistry, we've got these beautiful hand rests, which basically can act as venipuncture boards. So you want something basic to rest on. If you're going to do this sitting, sometimes what I'll just do is take the patient's arm and just place it on the side of my leg. However, this technique works fairly well as well. Unfortunately, which could be a bit of painful silence here as we're waiting for this bottle to fill. You can see that the bottle's filling up more and more and more. And I'm going to remove that bottle, hand that over to my assistant. I have another bottle right there, keeping my hand steady so the needle doesn't move, and place another bottle in with a vacuum. And you can see that this the blood is coming out again. And we're just going to basically wait here until this vial fills up adequately with an adequate quantity of blood as well. You can appreciate why we made the comment that you should only collect no more than 4 bottles and start spinning them down. We keep our centrifuge centrally located. Sometimes you can just keep it inside your room as well, depending on the size of your room. So as this is starting to draw to a close here, I have instructed my assistant to have the bandage and have a piece of gauze ready. And what I'm going to do here is I'm going to take the piece of gauze, apply pressure, the bottle's still engaged, right? Pull the bottle out, close the safety on the needle so that no one gets injured. I should have pulled the tourniquet off first before taking the needle out here. As you can see, I've sort of forgotten that. I'm just going to ask my assistant just to clean up that drop of blood off the patient's arm there. She's going to take over for me, and now I'm going to quickly grab the other vial of blood from there and walk towards our centrally located centrifuge, walking by my colleague here. And here's our centrifuge. As I told you, this is one I've had for a long time. I love using it. Basically putting the bottles across from one another, closing the safety mark on this, and placing this at 10 minutes. So we're going to come back after 10 minutes time, and basically you wait for the centrifuge to stop spinning. You take your bottles back to your room. What I've done here is the bottles are sitting in a bottle holder. What we have our staff prepare, as I mentioned, is these little kidney basins, which are sterilized with gauze and a cotton plier. I was putting an extra glove on there. Opening this area up, more or less what we're going to do is also open up our PRF GRF box. In this video, I'm not going to show you how the PRF GRF box works. We'll do this in a subsequent video. Remove some of those pieces of the sterile gauze as described previously. Take your bottle, crack your bottle open, and using your sterile cotton pliers, there's your your platelet-poor plasma, then you have the platelet-rich fibrin plug and the packed red cells on the bottom. So you're going to basically separate the packed red cells from the platelet-poor plasma, and sometimes you get some packed red cells coming off. Don't worry about that. Just lay that down on the gauze, right? And what we're going to do is basically take this piece of gauze on top here and allow that to absorb excess moisture from our platelet-rich fibrin plugs, which is going to help facilitate fabrication of the platelet-rich fibrin membrane. And we're going to move towards a second bottle here, and this is going to be the end of the video. So the next lecture is lecture 4, which is the pre-surgical assessment. Once again, as per previous videos, I've included the same references that we've included same references that I've included that we used in the production of this lecture series. Once again, I would encourage you to look up all of these references, as some of them are excellent resources to provide information beyond what I've been able to provide in this online lecture. On behalf of the entire team at the Cataraqui Woods Dental Implant Institute, I want to thank you for listening to our lecture.